Welcome to the Pacific Research Institute's Next Round podcast. I'm Rowena Itchon, Senior Vice President, and with me is Tim Anaya, Senior Director of Communications.
Ro, it's great to be back for another, what I hope will be interesting episode of Next Round.
So, Tim, what did you do on Mardi Gras?
Well, normally what we love to do, every year on Fat Tuesday or around there, IHOP has this great deal where you can get a free stack of pancakes. You don't have to order anything else. You can just go in and get a free stack of pancakes. And I always used to love to go. We would go, for lunch. Sometimes I'd go for lunch and dinner. That's how much I enjoyed it. And their promotion, they raise money. I think it's for children's hospitals. But sadly, with COVID, it's another thing that we could not do. But fear not, you could sign up on IHOP to get a free stack of pancakes at some point. I believe it was during the month of April. So that's what I did. Instead of eating free pancakes, I signed up for a free coupon for pancakes.
For Ash Wednesday, normally I would go and get ashes, but I watched Mass on my phone. So I didn't get ashes this year. As you say, these are unfortunately COVID times. Well, this week's podcast featuring our healthcare panel at the Sacramento Conference is perfect timing because it looks like single payer is back in California. Last week, Assembly Member Ash Kalra of San Jose introduced the California Guaranteed Healthcare Act, or CalCare is what they're calling it, which would provide universal single-payer healthcare for all Californians. So, Tim, the last effort was in 2017, and the price tag back then was $400 billion, according to the Legislative Analyst's Office. That's nearly double Newsom's proposed budget for all of fiscal year 2021. Eventually, Speaker Rendon shelved the bill. So should we take this one seriously?
Well, I mean, it's a good question. Certainly Democrats in the legislature are feeling emboldened after the last election. And they think, after really kind of being put off by both Gavin Newsom and the speaker with this single payer commission that's been ongoing, I think they feel now is the time they want to press the issue. Maybe they also feel that Gavin Newsom is in a politically vulnerable spot right now, and maybe they can take advantage of that. I think that Gavin Newsom really, the last thing he wants to deal with right now, with all the problems on his plate, is a single payer bill. I don't know how forcefully he would come out on one side or against it. He has said he's rhetorically in favor of single payer. But my guess is Speaker Rendon will probably once again do the dirty work of the governor and shelve that bill in a committee, because the fact remains they still have not come up with a viable way to either implement or pay for this proposal. So it might be a political hot potato in the coming months, but I just would be very surprised to see that this proposal goes anywhere anytime soon.
Well, single payer actually polls pretty well in California until Californians find out they will actually lose their own private health insurance and their taxes will go up. So I'm not so sure that Californians have the entire picture of what single payer will do. So nevertheless, it's been pretty popular.
We saw that too in the national polling during the presidential primaries last year, where people liked the name, the title or the concept of single payer. But when you ask them, do you want to pay more taxes to pay for it? Support sank. Do you want to lose your employer-based coverage? Support sank. So that's exactly right. I think we would have a replay of that in California.
And Joe Biden said he wasn't for Medicare for all. Instead, he's planning on improving Obamacare, turning it into giving it his own brand, Biden Care. But his nomination for his point person on healthcare, Javier Becerra, was pro-single payer. You and I agreed last week that he'll probably have a tough time during the hearings, but he's likely to be confirmed. You still believe that?
I think so. I mean, it's going to be tough. I mean, as we've seen with the Neera Tanden nomination, you've got to make sure all 50 Democratic senators are happy if you're one of the cabinet nominees. Though I do think that single payer could potentially complicate these hearings, because one of the issues with a single payer proponent like Becerra being confirmed is, say lightning strikes and California does enact this CalCare proposal or something similar, it would still require a waiver of the federal government to put it into place. And will a Secretary Becerra allow that waiver for California when the president probably would not? I don't know. That's going to be interesting to watch.
And we're still going through this saga of school reopenings Monday, and it seems like every day it takes a different turn. Where are we today?
Well, we've had some movement in the past couple of days. Late last week, Democrats in the legislature released Senate Bill 86, which they're calling the Safe and Open Schools Plan, and it's being talked about as a, quote, school reopening plan. But if you look at the details, it's certainly not a very aggressive one. What it says is that it would require schools to offer in-person learning to, quote, vulnerable groups of students. So, for example, English language learners or homeless students, or those who don't have access to a very good distance learning tools. And then it would also say that schools that are in the red tier, which is under 7 new cases of COVID-19 per 100,000 residents, they would have to require in-person instruction to all students in K through 6 by April 15 under the proposal. Well, it seems like, I think they're trying to thread a needle between what Governor Newsom is pushing and what CTA is pushing. CTA, as of this writing, is lukewarm at best on this proposal. They're even running television ads across the state decrying this push for school reopening. And then you have Gavin Newsom, who said that he actually isn't really in favor of this plan, and he wants the legislature to do more. He actually said the bill doesn't go far enough or fast enough. So is this all just talk? Is this posturing? Is the legislature setting up Gavin Newsom to be the hero and come in rhetorically to open our schools? I don't know. I don't think, regardless of what the legislature does, they're not going to want to risk Governor Newsom vetoing the bill. It's in no one's interest, if you're a Democrat, to do that. So I don't know. The things are changing. By the time you hear this, things could have changed once again. But right now you have a legislature poised to move forward with I don't even know that I'd call it a lukewarm plan. And a Newsom, at least rhetorically, arguing to do more. We'll see what happens, and we'll see if this week is the week we finally solve this problem.
Yeah, it's a tough problem. And, you and I don't have kids, but it's got to be difficult for parents. Here's some housekeeping. We've got a great debate coming up on the role of social media and free speech. What's great about this webinar is we have a libertarian on one side, Bartlett Cleland, who's a prominent analyst in the tech space. And we also have distinguished conservative Dan Oliver arguing for the conservatives. And of course, you've got a great moderator, former Congressman Chris Cox. So listeners who have been watching this debate know that the right is divided on this issue. Some argue for more regulation, others arguing that the regulation is fine now. So it's really going to be terrific. It's March 2nd, and you can sign up for it on pacificresearch.org. So for this upcoming podcast, as we mentioned, it's our healthcare panel from last month's Sacramento Policy Conference. So how about introducing the panelists, Tim?
Sure. We have what we call, and we all affectionately call, PRI's Healthcare All-Star Team. We have our President, CEO, and Thomas W. Smith Fellow in Healthcare Policy, Sally Pipes, talking about just what we discussed. Where is President Biden going to go on healthcare? What will his, quote, Biden care plan be? What does the public option mean? She gives a great presentation, really diving into all those issues and what we can expect from the Biden administration on healthcare. Then you have our Dr. Wayne Winegarden, who talks about these issues that he has written and studied about in recent months about healthcare entrepreneurship and the importance of entrepreneurship to addressing our healthcare challenges. Things like telehealth we never would have had without entrepreneurship. And then you have Dr. Henry Miller, who talks about all of the debates that we're having about government approval and distribution of vaccines, kind of all these issues related to government policy on vaccines. So I think it's a very good, well-rounded panel discussion with lots of different perspectives on all the lessons we've learned about healthcare during COVID-19. So I hope everybody listens in. It's a very interesting discussion of all these healthcare issues. And don't forget, too, at the beginning, we have our chair of our California committee, the Honorable Dan Kulke, who kind of gives some overview comments about potential for free market ideas to take shape and inspire the forming of untraditional political coalitions during the COVID-19 crisis. His comments really set up very well the kind of our thinking behind this year's conference and some of the ideas that we're presenting across all of these different panels.
Great. Thanks, everyone, for listening, and we hope you enjoy it.
So to lay the foundation for our conference, I'd like to introduce the Honorable Dan Kulke to offer some opening comments. Dan is a PRI board member and the chair of our California Reform Committee. He's a retired partner with Gibson, Dunn, and Crutcher. He served for 5 years as an associate justice of the California Court of Appeal, Third Appellate Division. Back in the day, he also served as Legal Affairs Secretary and counsel to Governor Pete Wilson, and he acted as Governor Arnold Schwarzenegger's lead negotiator for tribal state compacts. Dan, over to you. Thank you so much for joining us today.
Thank you, Tim, and thank all of you for joining us here for PRI's third annual California Ideas in Action Conference. As Tim mentioned, we are meeting here today virtually as a new administration is taking office that is friendly to more government regulation of the economy, the environment, energy, and healthcare in a country whose prosperity was based on less government regulation, limited government, and free markets. It is no coincidence that the year of this country's birth, 1776, was not only the year of the Declaration of Independence, but it was also the year that Adam Smith published his famous book, Wealth of Nations. Now, the Declaration of Independence, as you know, was a revolution in political thought. But Adam Smith's book, The Wealth of Nations, was really a revolution in economic thought, explaining that free markets based on self-interest would generate prosperity. And these two documents that were issued during the birth of this country really shaped the thinking of our greatest Supreme Court Justice, John Marshall. John Marshall's early interpretations of the US Constitution protected the right of property and the right to contract, both of which rights are critical to the accumulation of capital and thus free markets. And it's interesting that it was the protection of those rights that distinguished the US economy from the economies in Latin America. I'd like just to emphasize this, to quote from historian Paul Johnson and his book, The History of the American People. He said that Marshall's rulings, quote, made the accumulation of capital possible on a scale hitherto unimaginable and saved the United States from the demagogic, legislative, and governmental follies which made property insecure in Latin America and kept it poor. Sadly, these principles, these constraints have been lost in the past decade in California. California's government has proposed policies and enacted policies that have strayed from these fundamental principles of constitutional and economic principle. For instance, California, right before the pandemic, enacted a $15 per hour minimum wage that hurt struggling small businesses and reduced opportunities for jobs. California locked down many businesses without regard to whether or not they could continue safely operating with reasonable safeguards against the virus. California, over the past 10 years, has enacted energy mandates that have increased the cost of energy while reducing its reliability and diverting funds that could have been used to strengthen our energy infrastructure, which can spark wildfires. Now get that. That is really a trick. A product where you increase the price and make it less reliable. California has also enacted since 2009 laws that would restrict the use of water by businesses and residents, while at the same time doing virtually nothing to significantly increase water supply through water capture projects or water storage projects. California has restricted the ability of a worker to be an independent contractor, even if they want to be an independent contractor, for that additional flexibility in their schedule. California's imposed new restrictions on the operation and expansion of charter schools, which deny students, particularly students in communities of color, a choice for where they go to school. So it's no surprise that the Tax Foundation, in ranking the 50 states in the United States, ranked California 48th in business climate and 48th in regulatory burden. In fact, California's cost of living is 50% more than the national average. Our housing is increasingly unaffordable, as you know. Homelessness is a crisis. And major businesses recently have announced their decision to move their headquarters out of California, including Charles Schwab, Hewlett-Packard, Tesla, and Oracle. So today's conference and the panels you will hear today are going to talk about how we can restore California's luster through free market principles that through the centuries have been so critical to the U.S.'s success. So our first panel will be our all-star healthcare team of Sally Pipes, Dr. Wayne Winegarden, and Dr. Henry Miller, who will talk about the lessons learned about healthcare during the pandemic. Then we will move to the authors of PRI's upcoming book on homelessness that will talk about solutions to the homeless problem that are both effective and humane. And then finally today, our education leaders will talk about the new threats posed to charter schools and what we can do to give every child the opportunity for a first-rate education. Then tomorrow, our policy insiders and economists will discuss how free market principles can be key to boosting the California economy and prosperity for all. We'll then move to a panel tomorrow on water policy, and that panel will discuss how free market economics, including water markets, can possibly be a solution to California's water problems. And then finally, we are very pleased to announce that the new Congresswoman from Southern California, whose district encompasses parts of Orange County, Los Angeles, and San Bernardino, Congresswoman Young Kim, will give the keynote address and our closing remarks. So let me close in this introduction by noting that it is unfortunate but historically true that a society's success can often sadly lay the seeds for future failure, as that society loses sight of the reasons and causes that it was successful, while at the same time finding that what were once minor problems seem to be more significant problems in light of the earlier success, and the remedies then to those minor problems actually undermine the causes that allowed that society to succeed. So this conference today is about rediscovering those free market principles that help societies become prosperous. Free markets have been the most significant driving force over the past 200 years in creating successful, prosperous societies. And as Milton Friedman said, one of the great mistakes is to judge policies by their intentions rather than by the results. And free markets are all about achieving results. So with that, I'd like to turn the program back over to Tim, who will introduce our first panel. Thank Thank you very much.
Thank you so much, Dan. So our first panel today, as Dan mentioned, focuses on healthcare. And starting off our panel discussion today with a discussion of President Biden's plans for Obamacare and single payer and all of these kind of issues is PRI's President, CEO, and Thomas W. Smith Fellow in Healthcare Policy, Sally Pipes. A little bit on Sally. Before joining PRI in 1991, she was the Assistant Director of the Fraser Institute in Vancouver, Canada. She's the author of the most recent book, False Premise, False Promise, The Disastrous Reality of Medicare for All, which was #1 on the Amazon.com for health law books. We're very proud of that. You may know Sally from her regular columns for Fox News, Forbes, and the Washington Examiner. And you see her frequently with her media interviews, speeches, and debates. And she's always called upon to go talk healthcare policy with policymakers in Sacramento, Washington, and around the country. And we're looking forward, to her sharing her ideas for how we can provide better quality and access to healthcare while lowering costs. So without further ado, Sally, the floor is yours. Welcome.
Well, thank you, Tim, and it's a delight. It's hard to imagine on October 1st, I'll have been running PRI for 30 years. Of course, I was 12 when I started. So anyway, it's difficult. It's going to be difficult to talk about how we can bring free market approaches to healthcare right now with the current team in office, both in Washington and in Sacramento. But anyway, it's hard. I can't actually believe that the Biden administration has only been in office for 2 weeks and a day. They've done a lot in the first 2 weeks, and I hope some of the bad things that they're doing are going to slow down. The Democrats' victory in the 2 Georgia Senate races, which was a bit of a surprise, basically put the hands of the Senate into the Democrats. And while that split is 50-50, Vice President Kamala Harris has the power to cast any deciding vote and break a tie. And as everyone on this probably knows, Kamala Harris was the Attorney General in California. She is a very progressive person. And she, of course, was a big supporter of Medicare for all, single payer. In the Senate, she signed on to Senator Sanders' 2 Medicare for all bills in 2017 and in 2019. It is going to be very, very difficult because of the razor thin edge in both the House and the Senate for the Biden team to get through Congress Medicare for all or Biden's building on Biden care with his public option. And I think also there are a couple of senators that are Democrats that probably would not go for a couple of these things. And one is the Democratic senator from West Virginia, Mr. Joe Manchin. So he has very much said he's against single payer and even some of the things in the stimulus. So cheers to Joe Manchin, and maybe he should switch to the Republican Party. But there are many, many things that the Democrats can do to turn Obamacare into Biden care. And they're going to command huge sums of taxpayer dollars. So let's take a quick look at Biden's agenda. Unlike the single payer goal that Senator Sanders had, remember during the campaign, Biden said, "Oh, I don't like Medicare for all, I'm not for that." But he does have what we call a stepping stone approach to single payer by the idea of the public option, a government insurance plan that would compete against private insurers in the exchanges. So don't be fooled. He does deep down believe in single payer, and so many people in his administration are supporters of single payer. So let's look at the parts of his healthcare agenda. One, he wants more generous subsidies for exchange coverage, premium tax credits for those earning between 100 and 400% of the federal poverty level. That's a family of 4, that would be $105,000. 8.3 million have signed up on healthcare.gov, and the total on all the state exchanges and healthcare.gov enrollees this year is about 11.4 million. This is an unbelievably low number when you consider what the turmoil it's caused in the healthcare market. On January 28th, Joe Biden signed an executive order setting up an Obamacare special enrollment period called an SEP from February 15th until May 15th. He had said during the pandemic that many people had lost their jobs and therefore their health insurance, and they could not afford COBRA coverage, which is about $7,400 a year. But this new SEP would allow them to sign up for Obamacare coverage now. But this is really window dressing, because what Biden did not tell the American people, and what the American people need to know, is that if you lost your job during a pandemic, or if you had domestic abuse in your family or whatever, you were free to sign up for Obamacare, and you weren't subject to just the rules of the open enrollment period. So as I say, this is nothing new. People could have signed up. And so it's really window dressing that he thinks is going to give him more kudos in the polls, I think. He also is going to add $50 million to be used for advertising, exchange coverage, and enrollment assistance. Remember the navigators. This amount back in 2013, 2014, when Obamacare came in, was about $100 million. And it didn't attract a lot of people to the exchanges. And of course, Mr. Trump cut that money back to 10 million. But Mr. Biden is going to add 50 million. In addition, many Americans who are eligible for subsidies, about 86% of the people on the exchange plans are eligible for these subsidies. But he has now said no one would spend more than 8.5% of their income on a premium. And tax credits would be based on the higher cost premium gold plans rather than the silver plans, which is the case now under current law. So if you look at the Obamacare coverage with the 10 essential health benefits, between 2014 and 2020, the average monthly premium on the exchange ballooned from $264 a month to $523 a month. So is it any wonder that many Americans did not sign up for exchange coverage? Not only are the premiums expensive, the deductibles are very high, and the networks of doctors are very narrow. So also under the exchange plans, a number of people during the last few years, their income went above 400% of the federal poverty level. So they weren't eligible for the subsidies, so they dropped out of the exchanges. The 2.5 million people out of the 11 million people dropped exchange coverage because they didn't get the subsidies anymore. Under Obamacare's mandated 10 essential benefits, as I say, high premiums, high deductibles, narrow networks of doctors and hospitals. I think the Democrats are also going to try and expand Medicaid. You know, under Obamacare, only 12 states did not expand their Medicaid plans. I think Mr. Biden is going to entice the remaining 12 states into Medicaid expansion by offering to pay 100% of the premium. You know, the other states, the coverage went down to 90%, but he's going to try and entice them into Medicaid. And we now have 70 million Americans on Medicaid, the program for low-income and disabled Americans. So this is going to be another high-cost adventure that Mr. Biden would like to take on. He also wants to introduce price controls on pharmaceuticals, tying them to most favored nation. And Wayne is going to talk about that, so I won't get in and steal Wayne's thunder. But anyway, those are drug importation from Canada. Joe Biden also said that he wants to reduce the age of eligibility for Medicare from age 65 down to 60. And the CBO has already forecast, I think people don't realize this, that Medicare Part A, the hospital part, is forecast to go bankrupt by 2024. There are 60 million people on Medicare today. And if Joe Biden is able to get the reduction in age from 65 to 60, 23 million more Americans will enroll on Medicare at a cost of $100 billion a year. And we're currently spending $800 billion a year on Medicare. And as many people know, particularly if you're on Medicare or about to join Medicare, 1 in 3 new Medicare eligibles cannot find a doctor because doctors are reimbursed at about 40% below what they get paid for treating private patients. The other thing is that for those people who lost their jobs, as I mentioned, he's expanded the special enrollment period, but he is also talking now about providing subsidies for that COBRA coverage, which, as I mentioned, is about $7,400 a year. He wants to subsidize COBRA payments through September of this year. Just a few, Tim, how much time do I have left? I know we're on a tight schedule.
Just a few more minutes.
Okay, good. Well, just a couple of things. Biden's public option plan, a government-run insurance plan that would compete against private insurers. He wants the government to provide this public option, which will ultimately crowd out private insurers, because the government will price their plan cheaper than private insurers can provide it. And so private insurers will have to be paying more and more, and ultimately will be crowded out of the plan, and we'll all be left in what, of course, Mr. Sanders, AOC, Kamala, and even Joe Biden want. We'll all be left in a single-payer healthcare system. Just a couple of words about the nominee for the Secretary of Health and Human Services. That's Javier Becerra. Many of you know his name and his reputation. He is a big supporter of Medicare for All, both when he was in the California Assembly, 24 years in the House. He's very much a supporter of Bernie Sanders' Medicare for All plans. He has brought, as California Attorney General, he took over in 2017 when Kamala was elected to the Senate. He's brought more than 100 lawsuits to the courts. He doesn't, against association health plans, against short-term limited duration plans. And then, of course, there's the major Supreme Court case, which is the first hearing was held on November 10th. And he is very much saying, and along with 20 other state AGs, that the law Obamacare is constitutional, even though the individual mandate has been removed. So he is a big supporter of more government. And I think Senator Tom Cotton he's sending around a letter saying, please say that Javier Becerra would not be a good Secretary of HHS. He has no health experience, and he is a lawyer who supports all of these terrible things. So I'm hoping that he doesn't get through the nomination process. But of course, one never knows. You could get someone even worse. But I think Javier Becerra would be a bad person. So just to close, and I answer any questions later, I would like to say that if you look at the way the government, both federal and state, handled the pandemic, the private sector brought those vaccines to emergency use authorization within 9 months. Moderna, Pfizer, J&J is coming up, AstraZeneca. And yet the federal and the state governments have botched the distribution and the administration of the vaccines. So if you think you want the government to fully take over your healthcare system, just look at the microcosm of what they did with the vaccines during the pandemic. So Tim, with that, I'll stop. So much more to say, but there's only so much time, and I don't want to steal from Wayne or from Henry.
Well, Sally, thank you so much. Now I'm happy to turn things over to our Dr. Wayne Winegarden, who is the director of PRI Center for Medical Economics and Innovation, and also a PRI Senior Fellow in Business and Economics. We give him so much to do. I don't know when he finds time in the day to do it all, but he has a very interesting presentation on all of these topics for us as well. So Wayne, with that, the floor is yours.
That's great. Thanks so much, Tim. And I'd like to welcome everyone as well. And thank you so much for coming. Sally has, as always, ended that perfectly in terms of lead-in of what I'm going to say, which was she was talking about private markets and the ability of private markets to actually deliver what we want. Right? In terms of healthcare, what we want is a more affordable, more innovative, higher quality of care, lower cost. And that's when you talk about, all these government programs, that's what they claim they want, but they're not going to be able to achieve it. I just have a few minutes with you here today, but what I wanted to do is start by talking about what we should be talking about. How do we create a more entrepreneurial healthcare sector, a more market-driven healthcare sector to actually kind of improve outcomes? Then what I need to talk about is pharmaceuticals, because too often in DC and state capitals, you hear people talking as if the way to address healthcare affordability is, just slap price controls on drugs. Drugs cost too much. We all know they cost too much. And what we all know is wrong. So I wanted to present that data to you so you can understand what's actually happening in the pharmaceutical market. And so you understand why drug importation and most favored nation and all of these crazy ideas are in fact crazy because they won't achieve what they purport to be able to achieve. I have a few slides that I prepared for you, and Evan, if you could kind of put those up. I think I'm going to disappear as the slides come up. Here we go. So if we go to the second slide, what we talk about in terms of healthcare, we always say we have a healthcare affordability problem, and that's correct. And there's lots of ways. We could spend an hour kind of diagnosing all the ways that healthcare has become unaffordable. But I think from a top line perspective, this chart will do. It's from the National Health Expenditure Data from the CMS, Center for Medicare and Medicaid Services, and it looks from 1960 all the way to the latest data, 2019, how much national health expenditures are relative to the size of our economy, relative to how much we can afford. And you can see, way back in 1960, it was about 5%. Now it's almost 1/5 of the economy. It's been about that level for quite some time. And certainly some of that growth is a good thing. We have new treatments, we can treat people with cancer and all sorts of other ills, so that those expenditures are going to increase because we're getting higher quality care. But at 20% of the economy nearly, you're talking about a level that's much higher than any of the other OECD or major industrial economies. And there's just a tremendous amount of fat in there. So we know we're spending too much on healthcare. If we go to the next slide, typically what you hear in the debate is, it's drugs are driving our healthcare problem. And this chart, I know it's a little complex, but we'll go through it very slowly. I think this demonstrates that, in fact, not only are pharmaceuticals not driving the problem, but in fact, administration, kind of the bureaucracy, is a big part of the problem. So this is the same data set, but now instead of looking at relative to GDP, we're breaking down the categories as a share of where do we spend that money. So the bottom bar is a dark kind of black color. That's the percentage we're spending on hospital care. And that also includes infusion drugs. The bar on top of that are professional services. So these are doctors, nurses, physicians' assistants. And you can see those kind of like the core that people think of when we talk about healthcare. And actually, as a share of our healthcare expenditures, we're actually spending less on doctors and hospitals today than we were way back in 1960. The same also holds for prescription drugs, right? It's 9.7% today compared to 9.9%. And what's growing as a share of our health expenditures is, in fact, the middlemen, health insurers, PBMs, government administrative costs. Our bureaucracy is growing, right? And those types of inefficiencies show themselves in paperwork. And that's something you hear doctors complaining about all the time, that type of paperwork. And that's growing. And that's actually a big part of the problem. So when you hear people saying, we need Medicare for all and Biden's plan and all these other ill-founded ideas, they're actually doubling down on what's kind of one of the underperformers in terms of healthcare expenditures. What we actually need, if we go to the next slide, is the exact opposite. And one of my favorite quotes from the president is, in this present crisis, right, government's not the solution, it's the problem, right? And when I think that's no more applicable than to our healthcare system, right? Government is paying 41% of all the costs now, and those costs that they don't pay, they're going to fundamentally influence. So government is created the current healthcare system. They are responsible. Doubling down on that makes no sense. And if you look at where we've seen entrepreneurship, and this is where I think that the idea, the title from the presentation really comes into play. If you look at what telehealth has done during COVID-19, if you see how quickly vaccines have come to patients, all of that is driven by the private healthcare sector. All that was enabled with getting regulations out of the way. And when we do that, we see the potential. We're not actually allowing that to occur naturally over time, and that's where we're seeing the lack of affordability. Another really important example of gene therapies. I mean, here we have cures to diseases. One of the, if you look at spinal muscular atrophy, SMA, which is a degenerative disease, it impacts infants and little children, causes paralysis and death. We now have a cure for that because of gene therapies. This is what the entrepreneurial sector is doing. And so as opposed to Biden care, if we go to the next slide, What we actually need is to improve on the entrepreneurial incentives in our healthcare sector. What does that mean? That means we need new payment models. So that instead of doing our fee for service, we're actually having some sort of pay for performance, where we're actually change how insurance works, taking it away from the current kind of prepaid healthcare that we have now, and actually have true financial insurance that insures against the financial risks of becoming sick or injured, and that we're distinguishing that service from the routine health services that we get. All of these can only be enabled on the demand side if we really expand our health savings accounts. Because right now, the third-party payer system means that patients aren't the demand side, insurers are. And by definition, when you have that type of interference in the market, you're not going to have a system that serves patients. You're going to have a system that serves insurers. And then on the provider side, the supply side of the market, if you will, we need to deregulate. The physician state licensing laws, I mean, that was one of the main obstacles to telehealth. There's others, that was a big one. When we reduced that obstacle, look at all the telehealth we've had during COVID, right? Scope of practice laws, allowing physicians' assistants to do more that they are actually trained to do. Getting rid of crazy requirements for government permission to purchase equipment. All of this type of deregulation will energize the market and actually create an entrepreneurial system that can help address the affordability issues. Instead of talking about this, and this is the conversation we should be having, right? Not about Biden care, not about Medicare for all, but how do we empower patients and how do we empower doctors? But one of the main conversations we are having, if we go to the next slide, is talking about drug affordability. And what that conversation is basically saying is we need price controls. Right? Whether you hear about importation from Canada, that Colorado and Florida think they're going to do, or price indexing, which was in the previous administration that they were going to do, all of Medicare for all of these are just forms of price controls. And price controls, by definition, wherever it's tried, whether it's rent control, whether it's minimum wage, whether you put it on healthcare, always comes with large and adverse consequences. It's not going to solve the problem because you're just basically kind of interfering with the kind of the efficient market process. We end up seeing reduced quality and increased overall costs. What it also doesn't do is it doesn't actually go through and understand what's happening in the pharmaceutical market and distinguish between the actual cost of medicines and the cost of medicines for patients, because that distinction is key if we're going to actually meaningfully improve kind of where the drug market isn't working. The first thing we need to realize, if we go to the next slide, is that for most traditional medications, the medications we purchase over the counter, right, most of those medicines are generics. Generics are low-cost versions of the branded drugs, right? And as of right now, 90% of all prescriptions that are filled at a pharmacy are a generic. What does that mean? Well, the vast majority of those, over 95%, are $20 or less. And according to Express Scripts, their average kind of member out-of-pocket cost is $11.75 for a 30-day supply. So the first thing we have to realize is when we talk about the drug affordability issues, that it is a tailored problem. Most people who need drugs have access to drugs with out-of-pocket costs, and that's key, with out-of-pocket costs that are really quite affordable. Now, where the problem occurs is that there's specific medicines, we'll talk about those in a second, whose prices are very expensive. If we go to the next slide, and we really don't have time to get into this, but I'd be happy to send all of the things we've written about this that can help you get more details. There's two fundamental prices in the pharmaceutical market that you have to understand: the list price and the net price. The list price is what the manufacturers announce. The net price is includes all of the discounts that have been paid. The problem is those discounts don't go to the patients; they go to the insurers. The patient's costs are based on the list price, not the net price. Again, this gets into very detailed in terms of formulary placements, things of that nature, and kind of what happens when you obstruct a market, when you create not an open market that's transparent, but you create an opaque market where there's a lot of complexity. But for now, let's just take it that patients are paying off of list price. And as you can see from this chart, right? And when you hear people saying, oh, the price of drugs are going up so much, they're referring to list price. Any study, like that new RAND study that came out, anytime you read in the news somebody saying drug prices are going excessively, they're looking at list prices. Okay? The cost of the system is the net price. And as you can see, for the past 3 years, net prices have been going down. But since patients out of pocket is based on list price, those patients who require expensive medicines are actually are reaping the adverse consequences. If we go to the next slide, we can see what those kind of drugs are specialty drugs, mostly biologics. These are the drugs that are helping us treat cancer, autoimmune diseases. All sorts of amazing discoveries have happened in terms of the specialty drugs, but they are actually, especially because biologics are very difficult to make, they are expensive. And so you can see traditional drugs where you have mostly generics, the group of columns all the way to the left is cost, right? The price, change in unit cost, change in price. We can see prices for those drugs are going down. What's driving us are those tailored costs, those patients who need the specialty drugs. That's where prices are increasing. We also see that's where utilization is increasing. So it's these specialty drugs that are high cost, right? Small minority patients who acquire these drugs, they're high cost. And since it's tied to those list prices, not the net prices, in effect, there's an inequitable cost shift. And to kind of get a sense of what is going on there, if we go to the next slide, and I think when I discovered this statistic, it was really light bulbs went off, right? If you look at total hospital expenditures in 2019, right, which is what systemically we care about, we spend 3 times as much in hospitals, 1.2 trillion, compared to the 370 billion on prescription drugs. So from a systemic basis, you say, okay, we spend more on hospitals, and that's what we need to focus on. But patients don't care about the total expenditures. They care about out of pocket. And the adverse, all of these like adverse incentives, what we see is that out of pocket, patients' costs are 50% higher for prescription drugs, 54 billion, compared to the 36 billion for hospital care. That's why patients care about drugs, and that's why it's a big issue. When people talk about affordability, we focus on drugs, but you can see that the problem is that there's an inequitable cost shift. Total expenditures are under control, and that this is a false kind of, when we keep talking about affordability through drugs, the solutions, the price controls that we're looking at are going to impact innovation. They would diminish our chance to develop the COVID vaccines that I know Henry is going to speak on in a moment, and it distracts us from what I talked about at first. How do we create a more entrepreneurial system? When we're talking about this, we're not talking about what we should be talking about. I think with that, I've pretty much run over my time, so I'll turn things back over to Tim.
Wayne, thank you very much. And next we have our Dr. Henry Miller, who is a PRI Senior Fellow in Health Studies. Henry, for years, worked at the FDA and has a lot of great firsthand knowledge in all of the topics we're all interested in these days about vaccine development and distribution, and he's going to share his comments on these issues that we all wonder about these days. So, Henry, with that, welcome, and we're so glad you could join us today. We're having a technical difficulty at the moment as we're figuring out getting Henry in here. Let me ask a question that just came in for Wayne from Bob. He wants to know kind of a clarifying question. Net price not going down, net price growth going down, correct?
Not correct. The one, I love that chart, but it actually is more appropriate for it to be columns, not lines. So that is the negative net prices for the negative signs for the net prices is actually the percent change from year to year. So I know the line is a little deceptive, and I think more appropriately it should be a column. So no, net prices for drugs have been declining. So we've had an actual decline in the price of drugs on a net price basis. And those are the branded drugs, not just the generics.
A question for Sally. You've written about this before. Governor Newsom has created this commission to explore how California might implement a single payer system. Is there any update on this? And
In your view, how would a Medicare for All system hinder healthcare in California?
Well, thanks, Tim. Yes. Well, the commission, which I wasn't appointed to, even though they said they were going to have a broad array of different views. The chap that I debated from Berkeley is on the commission, but as I say, I am not. The commission, of course, is on standstill right at the moment because it was sort of overtaken by the coronavirus. So I think there are 13 members of the commission, all people who are extreme progressives. I think maybe when the pandemic is over, maybe Mr. Newsom will reinvigorate the commission. But as everyone knows, there was a Medicare for All bill in 2017 in California, SB 562, and even the Assembly leader, Anthony Brendan, didn't bring it to the electorate because the cost would be $400 billion a year, more than double the state budget. So, and then during the Trump administration, if Mr. Newsom had tried to, bring a single payer bill if the Assembly and Senate had brought a bill for him to sign, he might have signed it. But Mr. Trump and the Trump administration would not have granted the waivers from the federal government to the state in order to allow them to have the money to pay for single payer. Interestingly, Javier Becerra, I think, would, if he does become Secretary of HHS, for states like New York and California that are thinking about state-based single payer, he would probably be willing and would grant the waivers so that these two states and maybe a few others would be able to bring about a single payer in the state. So that's a very worrying development.
Question for Wayne. We had a great study that we put out recently about the importance of entrepreneurship driving our healthcare system. Can you expand a little bit about kind of the premise of that study and your thoughts on this? How would more entrepreneurship improve healthcare and promote innovation?
Sure, and that's what I was trying to get at very quickly with the beginning. I think one way to think about it, and I was thinking about this the other day, actually it was about a year ago before the pandemic, but I was at the doctor's office, and you think about how familiar a doctor's office is today compared to when it was 10, 20, 30, 40 years ago, right? You can walk into the doctor's office and the chairs are almost the same, the magazines laid out. The way we're delivering care has not evolved at all with the way the economy has. I mean, think about any other part of our lives, and it would almost be unfamiliar to somebody if you took them from 1970 and brought them today. Healthcare and the delivery of that isn't, and that's part of the problem, is that we need to innovate kind of how we are delivering healthcare and who's empowered to deliver healthcare services. How can we use pharmacists, physician's assistants, doctors, use all of those more efficiently? How can we use health insurance to be much more of a financial instrument rather than a prepaid healthcare? All of these things would actually fundamentally change the incentives that are in our current system. And those incentives right now are not designed to improve kind of the way we deliver healthcare. They're not designed to improve our wellness. I mean, just the fee-for-service model alone kind of locks people into a certain way of operating. So I think that's when I talked about kind of a healthcare entrepreneurship, that's kind of what I was thinking, is that creative destruction that improves our lives everywhere else, all the other sectors. Think about Amazon, how shopping has changed. We haven't seen that in healthcare, and then we can.
Okay, this is Henry. I think I'm in finally.
You are in, Henry. Welcome. We figured out all the technical kinks. We're so happy you could make it in.
I am too. Okay, thank you all for participating, and apologies for the glitches. The pandemic has offered a number of policy lessons, some of which you've heard about from previous speakers. And most importantly, they've also related our expectations, often negative expectations for the new administration in various policy initiatives. I'm going to talk mainly about the scientific and medical realm. And I think there, the most significant policy lesson has been the importance of being conservative in the sense of risk averse in the face of a pandemic. The SARS-CoV-2 virus, which of course causes COVID-19, is in a sense our worst nightmare. It's an organism that's easily transmissible, can cause serious illness and even death, and that has a long incubation period. And that enables it to spread before infected people become symptomatic. If we had taken the misguided advice early on of those who said we should let the virus spread widely, unchecked, to achieve herd immunity. Herd immunity, of course, is the point at which a sufficient portion of the population has been immunized either by natural infection or vaccines, so that the virus has difficulty finding new susceptible targets and the pandemic wanes. If we had let the virus spread widely, we would likely have reached or even exceeded the early estimates of more than 2 million deaths in the U.S. And also a word about those estimates or models. The early estimates were often criticized by people who don't understand modeling. The models change inevitably as circumstances such as the appearance of new viral variants, the imposition of public health precautions, and so on change. It's rather like using the GPS in your car. You begin your journey with an estimated time of arrival, but that changes during the course of the trip, depending on whether you're caught in a jam behind an accident or whether you drive over the speed limit and you get there more quickly. Now, recent preliminary studies from South Africa, where people who have had COVID-19 are in large numbers becoming reinfected with a new variant, indicates that the natural immune response in people who have been infected isn't making sufficient neutralizing antibodies. That's because of the new variant. But physical distancing, wearing masks, and avoiding crowds in indoor venues are among the small things that individuals can do that add up. Similarly, contact tracing by public health agencies can be extremely effective and requires little more than organization and the allocation of manpower. However, it's impractical when the level of community spread is high, as is the case currently in much of the U.S. and much of the world, in fact. Putting the South Africa and other recent variants in perspective, vaccines are likely to offer better protection than natural infection because they're designed to elicit a wider array of antibodies. But if vaccine efficacy is even slightly lower than expected from the vaccine clinical trials, and remember those trials were performed before the appearance of the new variants, that will raise requirements for herd immunity. That is, again, the percentage of the population that needs to be immunized in order to cause the pandemic to wane. The bottom line for this point is, if we fall behind the curve, the pandemic can quickly surge out of control. So we need to keep flattening that curve of infection, which accomplishes several things. It keeps our healthcare system from being overwhelmed, but also fewer infections mean less circulating virus, less viral replication, fewer mutants, and less opportunity for natural selection to spread more dangerous mutants or variants. Now, my second policy point, the most successful aspects of the response in the U.S. to the pandemic are a result of good public-private cooperation, both long-term and short-term. What I mean by long-term is the development of COVID-19 vaccines and therapeutics, such as the monoclonal antibody drugs from Regeneron and Eli Lilly, are a reminder of the importance of federal funding of basic, that is, pre-commercial research. The federal funding of basic research that had no known application for decades after World War II gave rise to the advanced genetic engineering technologies that have made possible the products used to prevent and treat COVID-19 today. In the short term, the government, the private and public sector cooperation was primarily the funding of a large-scale production of candidate vaccines early, that is, long before companies would ordinarily have built bricks and mortar facilities under the aegis of Operation Warp Speed. Warp Speed, of course, sped the development of many of the leading vaccines, although I hasten to add that the Pfizer-BioNTech vaccine was all private. Pfizer expended almost $2 billion of its own resources for development of its vaccine. My third point, many of the failures in responding to the pandemic have been due to government dysfunction rather than overregulation. For example, the CDC's sending out flawed coronavirus tests early on, not once but twice. The first set were completely invalid, flawed, and the second required a reagent that was in short supply, and so although the tests worked with that reagent, it was generally unavailable. Second was the FDA's failure to vet the validation of coronavirus tests, so the market was flooded with tests that were inaccurate or insensitive or flawed or completely worthless. There was a lot of fraud going on. Third was the White House meddling with CDC guidelines and putting undue pressure on the FDA for premature approvals. Fourth, federal officials misstating recommendations. And lastly, insufficient surveillance for new coronavirus variants, that is, RNA sequencing of new variants as they appear. Inexplicably, the U.S. is far behind some other countries in sequencing circulating variants. The fourth point I'd like to make is that high-tech solutions to the pandemic, such as vaccines and drugs, get the headlines, but low-tech approaches often work very well. These non-pharmaceutical interventions, as they're known, masks, social distancing, hand washing, and so on, are essential, again, to flattening the curve. Finally, the more we let science dictate policy, the better. These coronaviruses don't care about pandemic fatigue, political philosophy, magical thinking, or what's trending on Twitter. So, as I often say, science shows the way. Thank you all. I'd be glad to take questions, of course.
Well, Henry, we have about time for one more question, and I think it's a good one for you and a good way to close us out here. We've gotten this ahead of time quite a bit. There's been a lot of talk of herd immunity. So in your view, when do you expect we'll be at herd immunity, and what is that going to mean for us? Are we, going to go back to normal then? Are we going to be able to stop wearing masks and, stop social distancing? If you could take a couple of minutes to kind of share your thoughts on that, I think that'd be a good way to close our first hour here.
Well, that's a very important question. Evan, if you want to put up my first slide, there's a timeline from Dr. Bob Wachter, the chief of medicine at the University of California, San Francisco. It's a bit complicated, but he predicted that we might reach herd immunity around late September, early October. However, that estimate, that figure that he published, was before the appearance of these new variants. And as I mentioned, even a small decrease in the efficacy of the vaccines, that is the ability to prevent an infection, raises the proportion, the percentage of the population that needs to be immunized, either by natural infection or vaccines, in order to achieve herd immunity. And for some of these variants, especially the Brazilian variant, we're seeing some that there may be some resistance to being inactivated by the vaccines. So the bottom line of all that is that we may need new vaccines that create a situation sort of like the flu, where we'll have to be re-immunized every so often to cover new variants, new mutants that arise. Recall that the annual flu vaccines are trivalent, having 3 separate variants of flu, or tetravalent, even 4 separate variants that change year to year. And it wouldn't surprise me if we ended up with a similar situation with SARS-CoV-2. That is, that it becomes endemic in the population, and we need to keep preventing it with new vaccines, and also, I'm sorry to say, with those non-pharmaceutical interventions like masks and some distancing that we all wish would go away.
Well, on that note, I think, I wish we had 5 hours to get through all of these topics, because we could do a whole panel on every one of the topics that Henry and Wayne and Sally talked about.
If you like this episode, please tell your friends and subscribe to PRI's podcast at iTunes, Google Play, Stitcher, TuneIn, iHeartRadio, and Spotify. And when you're on these platforms, don't forget to give us a big 5 stars. If you don't subscribe to any of these, you can still listen on PRI's YouTube page, youtube.com/Pacific Research 1. That's the number 1. Thanks for listening. I'm Rowena Ichon. Hope you'll come back again for next round with PRI.